With the minimally invasive foot and ankle surgery technique, I have my three favorite ways to treat bunion deformity. Number one, simple bump off. Well, it's not simple, it's less complicated. So bump off of first metatarsal, and then with or without akin-type osteotomy at the proximal phalanx. Again, with or without lateral release, which is adductor release. Number two way is the Reverdin-Isham bunionectomy, which is my go-to MIS bunion procedure. Number three way is the reverse V, Reverse-Chevron, or reverse Austin type of a bunionectomy that it can correct the IM angle, and from mild to moderate type of bunionectomy with or without akin-type osteotomy, kind of same as the other one. If you want to watch more detail on reverse Austin or reverse V Chevron type MIS osteotomy, like I said, we're going to focus on Reverdin-Isham bunionectomy, which is my go-to MIS bunion procedure. And this is very special because I had the privilege and honor to invite the actual inventor of Reverdin-Isham procedure, Dr. Isham, to my webinar I did in the past. And he's my mentor, and I always bring him to my big events for MIS Cadaver Lab in the previous 5 years. But you will see more in depth his insights, his philosophy about minimally invasive foot and ankle surgery. And also, I'll give you a short presentation of Reverdin-Isham bunionectomy in that presentation.
Welcome to the Podiatry Profits Podcast, where you will discover how to get more patients and multiply the profits of your practice with minimally invasive foot surgery, proven marketing systems, and ethical influencing to your patients. And now, your host, board-certified podiatrist, best-selling author, speaker, and founder of TJ On Coaching and Consulting, Dr. TJ On.
Things were good until 2012. You all agree with me, insurance reimbursements are going down, and I found myself running 3 clinics, many employees, seeing 30 to 40 patients a day just to meet my revenue needs. So around 2013, 14, I was about to quit. I had a major burnout. I just wondered myself, what am I doing here? I went to MIS Cadaver Lab in 2014, and I met Dr. Isham. So that was my big turn point, epiphany moment for me. I saw minimally invasive foot surgery for the first time, directed by Dr. Isham. And for some reason, I just immediately knew this was the path I needed to take. So I went all in from that point. I went basically from typical traditional open surgery at the hospitals and surgery center to minimally invasive exclusive foot surgery at the office-based surgery suite. I knew that was my niche. I knew that was my specialty that I want to promote, and my gut intuition was correct. I started attracting more patients to my office and start creating great results with minimally invasive foot surgery. Again, so thankful that I met Dr. Isham when I was about to quit and change my career to real estate and Korean barbecue joint. I'm not joking. So you see some pictures here, my journey with Dr. Isham. Just to my small way of gratitude for what he has done to me, I wanted to hand down his legacy, his vision to promote and educate our colleagues with minimally invasive foot surgery. So I started programs, MIS Accelerator program, and I started hosting and organizing minimally invasive foot surgery cadaver labs, as you can see in these photos. And just to introduce Dr. Reverdin-Isham, he has devoted his career not only to practicing minimally invasive techniques, but also as a professor of surgery to teach these procedures at United States and abroad. His influence is prominent in pretty much all over the world. America, of course, South America, Europe, and Asian countries. He has pioneered and published articles on many of the minimally invasive surgical procedures currently in use, and several of these techniques actually bear his name. So again, to thank him, he is always invited as a head lab instructor of my cadaver labs that I'm hosting in Chicago. As you can see, he's helping hundreds of colleagues with hands-on guidance. And these are some photos from past 4 years. These are attendees, almost close to, I believe it was like 70 attendees, and we had 12 faculty. And you can see the photo of actual cadaver lab at the venue in Chicago. So please let me introduce Dr. Reverdin-Isham. And Dr. Isham, please turn on your camera if you don't mind. Awesome. Well, Dr. Isham, again, it's my honor to invite you to be a guest speaker of our event. Please say hello to everybody.
Hello, it's indeed my pleasure, and I feel privileged to be here with TJ and to spare some time with you doctors.
Oh, I mean, that's a really good compliment. I have your Reverdin-Isham first metatarsal osteotomy small presentation on your behalf.
Okay.
When was that developed?
Okay, I did that. I started doing that. Well, when I was doing the Austin procedure, I would do kind of like a mini open and do the cut so I could see it. And in my hands, I had to fixate it. So I wired it in place. And then I said, well, I did my Akins, and like I said before, my Austins were that I did an Akin with it turned out better. And I also did things like for bilateral, I would do a modified McBride minimal invasively Akin procedure, and one foot, and the other foot I would do a traditional Austin procedure, and I would compare the results. And very frequently, the patient would say, well, why didn't you do this minimal invasive procedure on both feet instead of the one open it up? And for a long time, it looked better and it functioned better. The patient had less pain. So I moved that direction. But anyway, by doing those, I corrected the didn't correct much the intermetatarsal angle. I did an Akin to get the toe straight. I removed the bump. I did lateral release or adductor release. And I didn't do anything about the PASA. That wasn't popular at that time. Even with Austin's, it wasn't popular at that time. And with my recurrences, I put down, well, why am I having these recurrences? And the big thing that stuck in my mind was the PASA. And so back in about 1980, 81, I tried with the Austin to try to correct the PASA a little bit by wedging it to some extent before we pushed it over. But it was a little more complicated. So I decided to say, well, maybe if I just do a Reverdin and but MIS, maybe I won't get the problems associated with the Reverdins, which was a reduced range of motion. But I did get reduced range of motion, even doing the Reverdin. So I looked at the X-rays, and a Reverdin for those is you have a cut through the head that goes from the end of the cartilage, functional cartilage on the dorsal aspect of the metatarsal head, straight perpendicular down to the weight-bearing surface. and that cut would end up going through the plantar surface of the head, just distal to the sesamoid bones. And so as the patient moved their dorsiflect their hallux, the sesamoid bones would run into the osteotomy site, and you ended up with hallux limitus, or restriction of range of motion. And so that was a problem even if I did it MIS. So I thought, well, what can I do? Because the x-rays look better, toes look better, but I had that problem. So I decided to change the direction of the osteotomy from dorsal distal at the end of the cartilage of the dorsum down to behind the sesamoid bones. And that's an angle that we call dorsal distal to plantar proximal, which is a really good angle because as you bear weight, you are compressing your osteotomy site.
Mm-hmm.
So you do not need to have fixation, and also you are inside the joint capsule. And as with most MIS procedures, you will notice that we call intrinsic fixation, where the body extensors and flexors and all that muscles will actually tighten up to protect the fractured bones or your osteotomies, the mother's nature's way. So anyway, that's part of it, fixation. But that's how I started with that. I did a series of about 1,000, no, not quite 1,000. The first time I got it published, I was teaching residents, and one of my residents said, "Well, Doc, you better publish this, because if not, somebody's going to steal it from you." So, God, I got to publish something? How do we do that? But anyway, I ended up publishing it in a podiatric journal called Current Podiatric Medicine, and it was published in 1985.
I see.
And then my next publication on that procedure was published in Clinics of Podiatric Surgery in the ends of the 1990s. There was a book on minimal invasive surgery, so I was invited to publish that. And at that time, I did put in a study of 1,000 cases, which was pretty remarkable, but how the results were. But I learned at that time, too, that as Dr. Isham, who invented the Reverdin-Isham procedure, that you don't do studies on it, because the studies don't mean as much, regardless of how well done or whatever it is. Well, he may have cheated. So I decided from then on out that any studies that would be done by somebody else. Okay, so that's why most of the studies that I've done are done by our orthopedic colleagues in different parts of the world. Okay.
Awesome. Well, I'll let you take a little break. I'm going to give you a little quick presentation on one of the best, in my opinion, one of the best MIS, not because he's in front of me. Well, this is my go-to choice of first metatarsal osteotomy, and doctors who's working with me or who are in my group, my accelerator group, elite group, mastermind, they know how much I love Reverdin-Isham procedure. So I made a quick presentation, borrowed some of his slides as well from Dr. Isham. So let me share this screen with you guys. In any rebroadcast, this is copyright, guys. So do not share any slides and information here on any other place. I appreciate it. So here difference between open and MIS. This again strictly for doctors who are kind of new to MIS. Open, typical traditional saw blade for osteotomies, usually larger incision compared to MIS, and more used with the internal hardware fixation. Versus MIS, we use one of the drill Dr. Isham just mentioned. It's a low speed, high torque. So it prevents burning the bones or soft tissue, less traumatic to the soft tissue. So we use that specialized drill. Osteotomies and exostectomies can be done 2 to 3 millimeter incisions, and most cases there's no need for fixation. Again, I'd love to say surgeon's discretion at the end of the day, but in my opinion, and then again, Dr. Isham here, and many other minimally invasive surgeons all around the world, pretty much almost there's no need for fixation on most osteotomies. Almost, I said, and surgeon's discretion. So that part we'll discuss after this presentation about fixation internally or not. So typical open and incision, that's a typical this side incision portal for Reverdin-Isham, akin type of procedure. That's a Reverdin-Isham. So let me give you a quick overview. Again, a lot of slides and photos here. Credit to Dr. Steven Isham and Mariano De Prado from his textbook, Minimally Invasive Foot Surgery. By the way, I want to find the good time to mention this. I know because you guys know about, like bad rep or history of minimally invasive surgery back in the 80s. That's the main reason why most traditional surgeons nowadays almost like never heard about MIS. Where I'm getting at, where most MIS surgeons had to shy away or hide away because of those kind of bad rep and incident back in the day. True master, this is why I love him and I respect him. True master of any field, in my opinion. I can say this with confidence because I'm big in martial arts and I see this common characteristic from any masters of their own field. They defend it like hell because they know what they believe in. They know what that can provide to help public health and patients. They don't go away. They don't give up. They don't give in. Dr. Isham is prime example of that. He decided to educate even more. So he started traveling abroad. When US is under attack, in a way, the MIS was under attack. He continued his journey by educating literally thousands of orthopedic surgeons all around the world. If you look at the first page of what we call Bible of Minimally Invasive Surgery, written by, Minimally Invasive Surgery, that's the title, written by Mariano De Prado, well-known orthopedic foot surgeons in Spain, and he was the chair of minimally invasive surgery for an ankle in Europe for many years. He wrote a textbook. If you open the first cover, it says this book is dedicated to Steven Isham. So he continued to defend what he believed in and what he had a passion, and continued to travel and educated all these orthopedic surgeons. That's why we have minimally invasive surgery modernized, improved, and the up level, it can be done in a sterilized environment and safest way to provide the best treatment options utilizing these MIS techniques. So I want you guys to take time and appreciate masters of any field. So these are some examples of journals and articles written by other doctors. Only on the left-hand side, that's a manuscript of his original Reverdin-Isham technique. But on the right-hand side, you start seeing they're talking about Reverdin-Isham technique performed and studied by other orthopedic surgeons. So this one is from Journal of Orthopedic Surgery and Research. I'm just going to go results. By the way, if you guys need any copy, you want to see actual reference, reach out to me, tjan@drtjan.com. That's my email address. I'll be happy to send you this reference. Results, Reverdin-Isham, here we go. Reverdin-Isham and akin percutaneous osteotomy with 48-month follow-up. AOFAS score was 87.15. And final follow-up 48-month, the VAS score was 8.35 out of 10. Significant improvement compared to preoperative values. Another article, Orthopedics and Traumatology by Bauer and Biao, Conclusion, percutaneous correction of mild to moderate hallux valgus by Reverdin-Isham osteotomy provided clinical results that were comparable to those of most minimally invasive or conventional procedures with 89% patient satisfaction and very satisfied at 2 years follow-up. So if some colleagues of us say minimally invasive surgery is not evidence-based, please, I'm going to be a little harsh on here, and that's an ignorant comment. There are hundreds of articles and studies published on percutaneous osteotomies. You just have been possibly blinded. There are articles all over, mostly written by orthopedic surgeons. Please don't say MIS is not evidence-based. It is evidence-based. Okay, so Reverdin-Isham osteotomy treatment goal, correct all the deformities of hallux valgus, both soft tissue and osseous components, and recuperate and maintain function of first MTPJ. So beautiful thing about Reverdin-Isham osteotomy, it corrects multiple, it's like three-dimensional correction. It corrects HAV angle, IM angle, PASA angle, and DASA angle. So Reverdin-Isham typically goes that small incision, and then you shave off the medial eminence first. So here's a little demonstration of photos, again credited to Dr. Isham and textbook by Mariano de Prado. That is dissection of cadaver. Usually these pictures were taken after surgeons perform MIS procedures, and well-known anatomist who is unfortunately passed away, he dissected out layer by layer to demonstrate how little damage that gets done into soft tissue or muscles or tendons or ligaments, other soft tissue structures. Am I correct, Dr. Isham?
Yes, as long as it's performed properly.
As long as you do it the right way.
That's right.
And then the next, this demonstrates the actually shaving off with 3.1 burr there. And then here's what Dr. Isham earlier describes as that DD, dorsal distal, right here, dorsal distal, right below, proximal to the cartilage, and then proximal plantar, that angulated wedge osteotomy corrects PASA angle and compress the osteotomy when patients weight bear. And what I found also, because of that angulation, it derotates the head because of the medial wedge, sesamoid position, it gets improved. And then there is the typical akin procedure here. And then it demonstrates right here about that DD to PP, dorsal distal to proximal plantar angle of osteotomy. Another cadaver lab demonstration of how osteotomy was performed. Okay. And this demonstrates how this corrects the PASA angle by wedge osteotomy. You're looking at the AP view of first metatarsal. Because of the wedge, when they compress, it corrects the PASA. And this demonstrates the akin angle. This is about dorsal medial incision and sweeping manner from medial plantar and coming up, leaving the lateral cortex intact, and creates wedge osteotomy of the proximal phalanx of hallux. And then you can see as it compresses, it corrects that HA angle. Some X-ray case study before and after. Again, this is shortened version. If you come to our cadaver lab conference, Dr. Isham usually have a full lecture on Reverdin-Isham osteotomy. So here is Reverdin-Isham, lesser metatarsal osteotomy of 2, 3, 4, and also the Isham hammer toe correction right there. This seems to be right after in surgery. And this image is from Dr. Isham. This is my case, Reverdin-Isham, before actually dressing the post-op, so you can still see the gap there. And I did on here sliding. The Reverdin-Isham is typically lateral cortex intact, but if you're not happy, you can complete the lateral cortex through and through, and then you can slide over. And I did the hammer to correction. Could have been better, could have been more transverse and a little bit more at the base. But what I can tell you also to you guys is that most MIS procedures are very forgiving, very, very forgiving, meaning patient has almost minimal pain and you can adjust it within 72 hours. If you're not happy with osteotomy or the corrected position, because there's no fixation, you can still adjust the osteotomy to better positioning and put splinting and bandaging. Here's another case, before and after. This one, I believe, you watch this clinical, looks beautiful. If you look at the x-ray to traditional open surgeons, oh, that looks crooked and stuff like that. But again, every actual positioning, most doctors here, I don't know what else you would have done with the traditional open. Patient was turned down other than Lapidus or first MTPJ fusion and arthroplasties of all the toes and wild procedure with the fixation. Patient didn't want to go with the fixation and she found me and then she's very happy. This, I believe, is like 8 months after you can see all the osteotomies were ossified, healed properly. And typically after 6 months more from here, you won't even see all this line of osteotomies. Now, I'd like to ask Dr. Isham a few more, questions. Now, what's your take on internal, fixation with metal or wire versus non-fixation? That's a hot topic, especially when it comes to first ray.
It depends what procedure you are doing. Obviously, you can do a procedure that necessitates fixation, like it's popular among the French. My French students that started doing this around 2000. The French were doing a lot of wild osteotomies for lesser metatarsals and traditional hammer toe procedures, etc. Well, they have abandoned the forefoot basically, except for the first ray, to MIS, and they do not fixate any of those. However, the first ray they like to fixate, and they do like to move that first metatarsal, slide it over with a modified like chevron, and they just slide it over so far that it's in the interspace that there's no way it's going to stay there unless you fixate it. And so they use 2 big screws to do that. I see no need unless you open it up and loosen everything up. But if you do it percutaneously, you leave all the capsule intact, the extensors and flexors are intact, and so therefore you can do your osteotomy, and there's no need for to fixate your akins. I haven't fixated an akin almost ever. So from the late 1970s till now, I have not fixated an akin. Sure, I can say, yeah, the surgeon has the prerogative to do that or not, but if I can get it done without fixating, then if you fixate, you're spending money you don't need, and you're doing unnecessary surgery. But I won't say that in a court. It's a prerogative, but that's my personal opinion, and it's demonstrated by, literally tens of thousands of cases throughout the world. So there are actually, the French has an organization they call Grey or Grey Meese, and there's another orthopedic organization that is formed that say, well, we disagree with the fixation. We don't use fixation, and so even among them, but among your orthopedic colleagues, fixation versus non-fixation is not a big deal. If you don't want to fixate it, that's fine. They've been fixing fractures for eons without fixation or cone fixation, whatever you need. Bear in mind that the bones of the foot are real tiny. If you do an arthroplasty, if you do an arthrodesis, that's where an indication to fixate is higher, because you're fooling the body. The body says, wait a minute, I'm supposed to have a joint here, and it's going to want to form a joint. So you're going to have to fool the body. And so in that case, a fixation tool or device of some sort is probably more indicated than not. But I don't fixate hardly anything. Obviously, there's some rear foot stuff that you want to do. If you do triple arthrodesis, you can do all that minimal invasive. You can do Dwyer osteotomies. That's all done pericutaneously, and of course you use a couple screws for that. So there are things that you use that more in the rear foot, but in the forefoot, I say, well, you can use it if you want, but it's totally unnecessary.
What about base procedure of first met? What is your opinion?
Okay, with the Reverdin-Isham akin procedure, that was originally designed for mild to moderate hallux valgus deformities. And so if you have an intermetatarsal angle and like 18 degrees plus, and the patient is younger than 50 years old, you should consider an additional procedure to close that intermetatarsal angle to increase your long-term success rate. And you can do that by doing a base osteotomy. Or you can slide the head over, but the more severe the bunion deformity is, as you slide the head over, you end up jamming the metatarsal cuneiform joint into hyperpronation, and the range of motion stops, almost like if you did a lapidus, and therefore you restrict the dorsal flexion of the hallux. That causes more hallux limitus. So if you review your pathomechanics of the foot and what causes things, the first ray has to plantar flex in order to allow the hallux to dorsiflex. That at the MPJ joint, it's only about 25 degrees, give or take. But if it plantar flexes, the first ray plantar flexes, then it increases that movement to up to 90 degrees. So if you do lapidus, you're limiting the function of the first ray and the function of the perineal longus that helps plantar flex that. So I'll just throw that out there at you guys.
Cool.
Okay, there I have a question here that says, how does the sesamoid bones move back position when the head is not being moved laterally? Well, with the Reverdin-Isham procedure, and you've seen with a couple of the x-rays, there was no base osteotomy, but the intermetatarsal angle decreased. And it decreased because you changed the biomechanical function. And it's that bowstring effect that when the sesamoid bones are displaced, if you want to say displaced, it's the bones that are displaced, actually pushes the first metatarsal more medially. But after doing the Reverdin-Isham osteotomy and your akin, now that force of the extensors and flexors is now straight back. And so the first ray is not pushed medially. And so that closes the intermetatarsal angle. Now, the sesamoid bones have been laterally displaced for quite some time, but they still are, most of the cases, they still articulate with the first metatarsal head. And so with time, they've created a functional cartilage there.
Mm-hmm.
And so by doing that medial wedge osteotomy, but obliquely from dorsal distal to plantar proximal, that rotates that functional cartilage. And with it, that causes the intermetatarsal angle to close and the sesamoid bones to stay in their functional cartilage area. Just rotating it. So that's how you can do, that's how that I don't have to play around with the sesamoid bones. And I learned that not having to play around with the sesamoid bones from Dale Austin. The bone debris in the osteotomy site. So you got a bone graft there. And so that also speeds up the healing process. So I hope I've answered your question.
Yes, because many doctors I've been helping, they were concerned, especially traditionally trained colleagues, when they look at X-rays without fixation, most of them get scared. Like, is there any case of non-union? And I know the answer already, but I'd like to hear from you.
Okay, you can have the non-union, but it is rare with a properly performed lesser metatarsal osteotomy. Otherwise, the French wouldn't have abandoned their wild osteotomy. But sometimes you have to realize, if you look at the X-ray, you go, well, it's a plantar flex metatarsal. I can see by the cortices and the length or whatever determination that we have a metatarsal problem with the keratosis underneath it or a diabetic ulcer underneath it. So you go, well, I got to do something, and you cut it, and the patient bears weight, and it moves. Well, it's supposed to move, and sometimes it moves where it's supposed to go. And so the body's going to move that bone to where it needs to go to resolve the pathology that patient has. So we try to guide it a little bit so it doesn't go too far with our dressings and that, but it's supposed to move. So I think as your surgical skills with MIS improve, there's less displacement. The more you do your osteotomies in the diaphysis, the more displacement you're going to have. The more you do it at the surgical neck, I'm talking about lesser metatarsals, the less displacement you're going to have.
Pioneers like Dr. Isham, they're the ones who went through trials and errors. And I don't want you to go trial and error, especially now, this modern society with all these insurance issues and all that. Healthcare systems broken. Do not reinvent the wheel. The fastest way, I believe, to implement these high-demand MIS procedures, especially in your office-based surgery, is to learn from somebody who has done it with a proven system. So skip the struggle. What if you have a system which shows you step by step, right? Especially help you implement an MIS fast and effectively, and business system that can create seven-figure, what I call Zen podiatry practice, not relying on volume and insurance hassles, right? I do have a proven mentorship program. One is MIFAS Accelerator, and the other one is the Mastermind. My MIS Accelerator program only focuses on helping you implement minimally invasive surgery with cadaver lab, online course, weekly coaching calls. It has proven to many colleagues who's now performing minimally invasive surgery in their office. If you want to develop further and build marketing skills and how to build strong, profitable private practice model, I do have a mastermind.
You've been listening to the Podiatry Profits Podcast with Dr. TJ An. To find out more about Dr. TJ An or discover how you can grow your podiatry practice, visit drtjan.com. Or you can also get a free copy of Dr. An's best-selling book, Opt Out: How to Take Back Financial Control of Your Private Clinical Practice Without the Hassle of Insurance Companies. Just go to optoutbook.com.